Hey there, we have a new alcohol withdrawal power plan going live today, actually, which is Tuesday, June 18th, 2024. And this is going to be a quick presentation to explain what's new with it and why I'm hoping it'll serve us a lot better than what we've had before. All right, so we've got the alcoholic patient. Why do they act this way? Well, we know alcohol is a central nervous system depressant. It does this via binding to the GABA receptor. GABA, or gamma aminobutyric acid, is an inhibitory neurotransmitter in the brain, so it's a natural brain relaxant. Alcohol binds to the GABA receptor complex and acts like GABA. But here's the problem. Chronic alcohol use leads to GABA receptor insensitivity. This means that more GABA receptor stimulation is going to be needed for brain relaxation. In other words, more alcohol to get the same effects as alcohol becomes more part of someone's life. Or more GABA receptor medication is going to be needed to calm an alcoholic withdrawing patient down. All right, so we just talked about how alcohol acts as a central nervous system depressant through its GABA effects. Now let's talk about what alcohol does with the NMDA receptors. When our body's own amino acid called glutamate binds to NMDA receptor, it causes neuronal excitation. Normal NMDA receptor stimulation is important for regulating mood, helping with learning and memory, and it's really important to a healthy sleep and wake cycle. Alcohol inhibits glutamate-induced excitation when it binds to the NMDA receptor. However, in chronic alcohol use, the body actually produces more NMDA receptors. So then if there is less alcohol to bind to these receptors, it means there is more receptors for glutamate to bind to, or more excitation of neurons, resulting in agitation, tremulousness, anxiety, insomnia. Classic signs of alcohol withdrawal. When alcohol levels become low in our chronic alcoholics, we see the effects of an insensitive GABA receptor and overactive NMDA receptor activity. Here is a list of minor and major withdrawal symptoms. The goal for our healthcare team is to try to keep our patients that are going through alcohol withdrawal at the minor to no symptomatology stage. We're going to really work hard to keep those major withdrawal symptoms at bay. Our main tool to keep patients from going into severe alcohol withdrawal are benzodiazepines. Benzodiazepines work at the GABA receptor to enhance GABA inhibitory central nervous system effects. But remember, chronic alcohol abuse makes GABA receptors insensitive to GABA, but it also makes it insensitive to benzos too. Higher doses of benzos will be needed to produce usual effects. I've got a chart here that shows you our different benzos that we use for alcohol withdrawal. We've got those that are longer acting, like chlordiazepam epoxide and diazepam, and those that are shorter acting, such as lorazepam and midazolam. The advantages of longer acting benzos for alcohol withdrawal is that they're self-weaning. If we use a shorter acting benzo for alcohol withdrawal, we may have to taper doses as we get towards the end of therapy. All right, now let's take a look in depth at this new power plan. Hopefully you have a copy of it available in front of you. So the first part has our general orders for all patients heading into alcohol withdrawal, including multivitamin, thiamine, folic acid supplementation. You'll note that there are two subphases that we have. One is utilizing the CIWA-AR scoring tool, and the other one using the M-Minds scoring tool. CIWA-AR scoring tool is for the verbal cooperative patient. This will be utilized on all of our units, where the M-Minds is for the nonverbal and or intubated patient. We'll see this mostly or really exclusively on critical care unit and maybe some on FAU. As we've said before, the mainstay of our therapy for staving off severe withdrawal symptoms is benzodiazepines. So what we have here is scheduled benzodiazepine therapy. We've got this being ordered hopefully on most patients who are entering into alcohol withdrawal, and it is scheduled. We've got longer acting choices like chlordiazepoxide and shorter acting like lorazepam. Note, we really would like to encourage oral usage. And since they are scheduled benzodiazepines, there are hold parameters. In addition to our scheduled benzos, there are orders for as-needed benzos for breakthrough withdrawal symptoms. And this is where our scoring tool comes in. These as-needed benzos will be given in response to certain scores. Here's an example where a COS score of 6 to 9 prompts the administration of chlordiazepoxide 25 milligrams, as compared to a COS score of 10 to 16 prompts the administration of 50 milligrams. The M-MIND subphase should be ordered for the nonverbal patient. These benzodiazepines are all injectable, and again, are administered in accordance with the M-MIND's patient score. Lower score, lower doses; higher score, higher doses. Also, in the M-MIND subphase, we do have a phenobarbital option. Now, the phenobarbital is a new tool for us at Elkhart General. Quick onset, about 5 minutes, but a long acting. We're looking at an 80 to 120 hour half-life. It's got an advantage over benzos in that it works on both the GABA and the NMDA receptors. As pharmacists, we need to be really taking a look, if patient starts on phenobarbital, the strong interactions. When we do utilize phenobarbital, it may be in addition to the benzodiazepine therapy. Of course, there's an increased risk of respiratory depression. Also, we switch over for monitoring phenobarbital to the RASS score, not just the M-MINDs. Also on this power plan, for all patients, whether they are in the CWA or the M-MIND subphase, is we have treatment for hallucination and or agitated delirium, and that is haloperidol. Note that haloperidol is administered in addition to our alcohol withdrawal therapy of benzodiazepine or phenobarbital. When we do use haloperidol, there's orders for a baseline 12-lead EKG, and also 12-lead EKGs for patients who have had more than one dose in 24 hours. And so this would be at least daily 12-lead EKG. And as we know, we're monitoring for QTC prolongation of these patients. Thanks for joining our alcohol withdrawal power plan education.